echoes. So we have on Thursday, January 16th, our echo primary care and STD will be hosted by Johns Hopkins, and then we will be back with UAB on the 4th and Johns Hopkins on February 20th with iron overload.
Awesome. Well, Happy New Year, everybody, and happy holidays. I'm very excited to have Dr. Genice Nelson with us today. She is a nurse practitioner. She's currently the program director at UConn. So anybody who logged in early heard her sharing just some of the amazing updates that they're going to be doing for their comprehensive sickle cell center starting January 31st. So congratulations. She's a national leader in sickle cell care. She has a DNP. She's made significant contributions to just improving the lives of individuals with sickle cell, emphasizing that patient-centered multidisciplinary care. She's a strong advocate. She's received the Excellence in Nursing and Research Award from the SCDAA, highlighting just your dedication to improving outcomes for those living with sickle cell. So I feel very fortunate to have you today to present on my favorite topic, which is mental health and sickle cell. And with that, I will hand it over to you. And once you finish, we will then have Ashley presenting a case, which is pretty interesting. And then we'll be able to wrap it up and get started with our day. So I'll hand it over to you now, Janice. Thank you.
Thank you so much. Good morning. So I'm presenting first, and okay, I'm perfectly okay with that.
Okay, perfect.
Let me share my screen. Do you see my screen? Okay, so, okay, good. Here, let me change because I feel like I'm not looking in the right direction. Okay. Well, good morning, everyone. Again, Happy New Year. I'm very excited to be here and share with you. Hopefully, this will just help give you some hints as to things to do with individuals who have sickle cell disease and sometimes mental health issues that come along with them having this chronic illness. Is it not going to work? So again, I have no disclosures. So mental health issues are very common amongst people with sickle cell disease, which we all know as providers. They can have depression, anxiety, and sometimes post-traumatic stress disorder. And this is all because of the frequency of their pain, which can have an aura or no aura, can be predictable or non-predictable. And because of the nature of it, it brings on this uncertainty, and this uncertainty helps feed into these issues of mental health disorders that they may be suffering along with their sickle cell disease. So we just need to be aware of it so that we can be in tune to help provide services for them when that need arises. So depression. Studies estimate about 21 to 44% of adults with sickle cell disease experience depression. So that's, for many of us, almost half of our patients may at some time during the course of their disease experience some type of depression, not necessarily lifelong, but they may have bouts of depression. And so we need to be in tune to that. And what does that look like for that individual who has sickle cell disease? So that may mean that they may not get out of bed. If they're in the hospital, it means that they may not open their blinds, they may not get out of bed, they may not interact with you very well. And so we need, again, to be aware of it. On top of them already having this chronic illness that can be debilitating, they now also have another illness that that they're struggling with. And so they may need some assistance. On top of the burden of the cost of sickle cell disease, anxiety and depression and mental health disorders also have a burden of cost. And so we need to be aware that sometimes insurances may not appropriately allow for services that these individuals may need during the time that they need it. So again, lots of nuances that we have to navigate in order to provide services for our patients. The prevalence of anxiety disorders in people with sickle cell disease is estimated to be about 6 to 29%. So again, a significant portion of our patients may have depression, about 50% of them, and some of them have depression and or anxiety as well. And so we have to get to a comfort level where we can diagnose that there's something going on. We may not be mental health providers ourselves and want to give them a diagnosis of anxiety or depression, but there are screening tools and things that we can use to help us discern that there are things that are going on in our patients. And we should not be afraid to say, hey, I understand that you're having some pain, but you also present that you may be having some depression. You're telling me your appetite is poor, that you're not able to get out of bed, you're not interested in doing things with your children or your family. And so we need to have these discussions the same way we would have discussions about, hey, does your pain medicine work for you? We have to get to a certain comfort level to be able to help navigate our patients into care that they may need. Because again, sometimes these services don't wrap around them and they don't have access to them. So we have to have a small repertoire of things that we're comfortable with that we can help our patients. Chronic pain and unpredictable nature of sickle cell disease flare-ups can also lead to PTSD. And so what does this look like in our patients? So the patient who has been in the hospital for a prolonged period of time may have ended up in the ICU and or been intubated, who now is here for their next pain event. And they are very, very anxious because they don't want to wake up again in the ICU being intubated, because now they associate that with their chronic and or acute pain. And so we need to be aware of these things because their presentations may be different, but it also may be heightened by additional worries and concerns because of what have happened to them previously. And so even though we need to take care of where they are right now, we also need to know that their history affects how they present to us and how we need to interact with them so that we can help them to have a safe space and feel comfortable sharing with us. I know that I have PTSD or I may have symptoms of PTSD. So we need to open up the doors so that our patients can have these conversations with us so that again, we can get them into services and into help. So other health issues can also affect them. People who have sickle cell disease often live in social isolation because they don't want to share that they have sickle cell disease because they don't want it to label them. They don't want people to treat them differently. They may see them as being weak. And especially in people who have several family members. Certain cultures also don't share that they have sickle cell disease because, again, it's a sign of weakness or imperfection. So we need to be aware of this as their providers so that we can help. Sickle cell disease can also, people can present with irritability, can have some degree of helplessness because, again, the nature of the unpredictable pain events often affects their moods. They can have low moods, sometimes suicidality, fatigue, which is a part of their disease as well, poor appetite, and sleep disturbances. So these are questions and concerns that we need to incorporate into our routine care for our patients to evaluate them to say, hey, yes, you have this chronic illness, but you also have some sprinklings of some mental health issues that maybe we can help to alleviate some of those symptoms to help your sickle cell disease to feel better. Because sickle cell disease, anxiety, depression, and pain all kind of go together hand in hand. So if you're treating their pain without treating some underlying depression and anxiety, you're not going to be as successful. Whereas if you're having open conversations and you address their anxiety, you address their depression and say, hey, maybe we get you into care, maybe we start you on some medications that can help with your anxiety and depression. It will also help your pain and make you overall feel better. So we need to have those conversations with our patients. Factors that can contribute to mental health issues also, chronic pain. Many of our patients have chronic pain. And if you think about it, if you were dealing with an issue that you had pain to some degree every day for years and years and years on end, at some point that has to weigh in on your not just your physical health, but your mental health as well. And so again, these are discussions that we need to have with our patients. Uncertainty. you know, the uncertainty of sickle cell disease, especially when you have a group of people who are together and someone dies suddenly and unexpectedly. They may take on the uncertainty of, it is my death now imminent because I've lost a dear friend that I went to camp with who had sickle cell disease. Trauma, that occurs in relationships or day to day. Trauma in individuals who have sickle cell disease, it significantly impacts their pain. Our social worker here at UConn actually did a study with patients who had a history of trauma and showed the correlation between their pain and if they were given therapies. She created a cognitive behavioral therapy program for them. And they actually, the arm that was in the cognitive behavioral therapy, along with medications, actually did better than the ones who were just on medication or who were just in counseling. So again, all of these things are interwoven together and contribute to the quality of life for these individuals. So it's really imperative that we understand this and that we have these discussions. So what can we do to support better mental health for our patients? So we can get them to talk to trained counselors. We can suggest that they use mindfulness apps. And sometimes using sickle cell apps to help keep track of their medications, their appointments, and their community groups is also very helpful for these patients. Where I am and in my role, I'm also over our behavioral health outpatient program. So I actually have the ability to fast track our patients into mental health care, which has been very beneficial. In our role, in my role, if I see a patient is struggling, or one of the nurse practitioners who work with me see that a patient is struggling, and we did some screening. There are several screening tools that you can use. Yeah, there's a anxiety and the GAD-7. Yeah, GAD-7, GAD-9. It's like I sometimes I get these numbers in it, but the GAD screening tool is a very good tool to use. And you, even though you're not necessarily diagnosing them, it helps to discern that there's something going on. And so there are some small things that we can do as sickle cell disease providers that can help our patients to feel better. The use of certain medications like Cymbalta. Cymbalta addresses anxiety and depression, and it also helps with chronic pain. So being comfortable and knowing what's available that we can use in our toolkit that's going to help their sickle cell disease pain and to help their anxiety and depression. I am very comfortable prescribing low doses of Lexapro, especially because I have this psychiatry program behind me that I can fast track somebody into to take over the medication management. So starting somebody on something like Lexapro, 10 milligrams once a day, typically it takes about 7 days. They start to feel a little bit better. And so while they're starting to feel a little bit better and they're being more open about what they're actually feeling, getting them engaged into care has been very helpful. We also have an IOP program, so people who may need a higher level of service, that's available to them as well. So what I would recommend is that you find out what services are available to you, make some connections with those services so that you can figure out how you fast track your patients into services when the need arises, because the need is definitely going to arise. We've had a couple of patients, one set of patients, actually a sister and brother, who suddenly and unexpectedly lost their mother. And so we were able to get them into bereavement care, which significantly helped the sister, because the sister actually had some suicidal ideations after her mother suddenly and unexpectedly died, because she was like, oh, I should have been a better daughter. I should have done this, And sometimes when people die, those unresolved interactions that people have come to the forefront, and the guilt that's associated with that also impacts people. So we just need to be aware as people that we're all sometimes struggling with something and trying to figure out what other things are available to help people with where they are. Sometimes support groups can be very, very helpful for individuals, and reaching out to find out again ahead of time what's available so that if somebody needs something, you can plug them into services has proven to be extremely important. Another thing that I would also recommend is looking at an individual's insurance. Sometimes if you look at individual's insurance, it will tell you what psychiatric services are covered, what's available, and will actually give you fast tracking into different services depending on their insurance. With COVID, we know that it has brought out that many people are suffering with different levels of anxiety and depression and other mental health issues. At this point, probably there are more people engaged in mental health care than ever before, which is a great thing because people are finally getting the services, that they need. That old mantra of what goes on in this house stays in this house is kind of out the window. People are reaching out and getting services that they need. And so we need to encourage our patients to reach out and get the services that they need as well. As you can see, I'm already talking about what we could do for our patients. I'm not sure if this is how you guys usually do that, but if you guys can open the mic and share some of your experiences or things that you may have been able to do to get your patients into service, I think that would be appropriate if we could do that.
I'll start and break the silence while other
I
people
can't
jump
hear
in.
you, Maya.
You can or can't hear me.
Oh, okay, I can hear you now.
Like these technical issues I'm having. Oh my God. I think the most important thing we can do as providers is just establish a relationship with our patients, because at the end of the day, we can't address our patients' mental health or encourage them to seek if they don't feel safe. And I think this is where the relationship and the time that we invest in just making our patients feel comfortable, seen and heard and validated is paramount to being able to really help these patients beyond just treating the sickle cell. So I think we develop the relationship. Our job is to kind of point out tendencies or point out our observations that might not be noticing. And you mentioned with the pandemic, it highlighted a lot of mental health. And I can say for myself, 100%. I had twins born. I was in lockdown with 3 under 2. And all of my buckets were overflowing. I was losing control, and my high functioning anxiety used to always joke about made me realize it's actual anxiety. And through my own personal experience, I feel like I've been able to help a lot of my patients because my tendencies of being a perfectionist and a people pleaser, an overthinker, overanalyzer, I was able to see where it's rooted in. And by sharing my own experiences of whether it was having overly critical parents or just anybody who's learning that love is conditional, you're going to have some mental health issues. So I think we can use ourselves to kind of be that mirror, or shine a mirror to our patients so they can realize that life doesn't have to be as hard. And just because you've been doing something a certain way doesn't mean it always has to be that way, and just continue to encourage and continue to circle back, because most of the time they will say no just because it is still very stigmatized. But I think we are slowly improving, and connecting to the CBOs and the advocacy groups on the local standpoints, I think has been very helpful as well in our experience.
Thank you for sharing that. That's absolutely 100% correct. And those are the things that I hope all of us are doing with our patients. I think having that relationship with the patient, of course, is the basis for any of the work that we are doing with our sickle cell disease patients. Because if they don't trust us, we're not going to be able to even help them manage their sickle cell disease. But if they trust us enough, to help them with their life issues as well. And since we are a trusted source for them, I feel that we should equip ourselves to be able to meet that need. If anybody else want to share or have anything that they would like to add?
Hi, this is Gay.
Okay,
Hi, Jenice, how are you?
I'm good.
I agree with Maya. I find that, when you let patients know that, you're human just like they are and you've sought out counseling, I think it makes them a little bit more accepting, because I feel like it lets them know that we're, in a sense, all the same. And, you know, I've had patients tell me that by me sharing my story of, after the pandemic, like going into therapy, that it really encouraged them to seek therapy as well. Also, in our internal medicine practice, we had a wonderful behavioral health specialist that I would refer patients to, who did counseling with the patients. She actually had this app that she would have the patients use to help with coping mechanisms and strategies, which was really cool, because she was actually able to track the patients using the app, and it really spoke to the patients that someone was really, truly looking out for them and was just as engaged as they were. So that was really useful for our patients.
Yeah. Anytime we can share something outside of us that our patients can feel comfortable using. And many of these apps are very helpful in helping them to be able to relax and help them to give them some form of distraction, to help them to cope with some of the things that they're going through is absolutely fantastic. And if we're able to track that to see that they're actually using it, um, in the way that we're recommending it to them, that's fantastic. It's like, can you share what that app is? Because maybe I can mention that to our behavioral health program, because to know that the patient is actually using it, it would be highly beneficial.
Okay, I can reach out to that behavioral specialist and get the app for you and get back to you. I don't actually know the name of the app, but I certainly can reach out to her and get that app for you.
Perfect. That would be great. I think anytime we have the ability to know that our patients are actually engaged in something that's beneficial to them, that we should take advantage of that. So I would love to share that information with our outpatient behavioral program, because that wouldn't be just for sickle cell disease, but for any disease process that they're helping with. That would be terrific. And I do think that for those of us who have engaged in some degree of counseling, sharing that with our patients does help to normalize their access into counseling for them as well. Because none of us are so strong that we can just do everything and not sometimes need to have our own coffers refilled. And so to show that vulnerability or share that with them does help them to normalize it and to make it less stigmatized. Oh, well, Janice went and she got some counseling and she said that helped her. Then maybe it'll help me. And and so I think that it's important for us to humanize ourselves and be vulnerable with our patients, especially if it's going to be beneficial to them. And sometimes we haven't, you know, pre-COVID, we didn't do a good job of being more vulnerable with our patients. But I think COVID has changed a lot of the way that we think and how we interact with each other and our patients. And I think that vulnerability um, that COVID put all of us through has allowed us to have a more humanistic touch, and really feel comfortable in like hugging our patients and those kinds of things. Because I have patients who every time they walk in the door, they're like, "Oh, I need my hug today." Absolutely. And you never know how that touch impacts them, because maybe that's the only hug that they've had all week long, and they need to know that somebody cares enough to say, "Hey, let me put my arms around you and just share some warmth with you for just a few seconds." And we should all be able to be vulnerable like that with our patients. I don't think I have any more slides, because I wanted to have a discussion about how we can interact with our patients and how we can be human and how we can share and normalize this for them. And hopefully some of the things I've said have been helpful and have given you some insights into some of the things that you may want to try with some of your patients. Like I said, find what's going to make you comfortable, find information and have it on hand so that if you need to plug people into different services, you have that available, and just normalize it because it is a part of life, just like anything else. So thank you for this opportunity to present. Again, I hope it's been helpful.
No, this was wonderful. Thank you so much. Does anybody have any questions or comments or feedback for Genice before we switch to the case? Or even Genice, like what's your typical approach? Like if you're noticing a person is having depressive symptoms and whatnot, how do you typically approach the conversation, just in case people don't necessarily know how to navigate without making a person feel like uncomfortable or feel triggered or feel like they need to get defensive? Do you have any recommendations on how you
Sure.
navigate
So
the initial approach?
I'm glad you actually said that. So I had a patient recently who we were having a discussion, has had a recent influx in pain. And the things that we were doing to try to help their pain just didn't seem to be impactful no matter what it was. If we increased the medicine, changed the medicine, it just didn't seem to be impactful. And so we were doing a virtual visit, and it just so happens that her mother happened to overhear me asking her, well, how were you sleeping? How were you interacting in the house? And so she goes, oh, I'm sleeping well. I'm doing this. And the mother said, excuse me, can I come in there? It's like, if you don't mind, can your mother join us? And she was like, no. So her mother came in. So I started asking the questions again. And so her mother said, well, she doesn't really sleep. She's up walking all night. And I was like, oh, okay. And it's like, well, what do you do? She goes, she's really OCD and she's doing a lot of cleaning and she's doing this, that, and the other. And she goes, I really feel like maybe what you're asking is probably, she goes, well, I don't see me as being depressed. I said, well, we don't typically see ourselves as being depressed. We don't see ourselves as being anxious. But if you're having these kinds of symptoms, maybe what your mother is observing is enough for us to figure out that maybe you are having some anxiety and some depression. And she was like, oh, okay. I said, do you recall we probably had this conversation before? She goes, no, we've never had this conversation before. Her mother goes, oh, no, we did have this conversation before 2 years ago. So with her mother kind of reinforcing some of the things that she's heard before, we were able to open the door. So in that particular instance, with her mother being there, that made it very helpful. But I have another patient who's been a little bit more um, I'm going to trust in God. And people who are very religious and have very strong faith convictions tend to give a lot of pushback. And so I said to her, I said, I'm glad that you believe in God and that your faith sustains you. I believe in God as well, but I also believe in God and a therapist. So since I believe in God and a therapist, how about we have that discussion about God and the therapist? And so when I said that, she started laughing, but it made sense to her. And I said, because I believe in God and I do. I go to church all the time. I'm active in the church. I said, but I don't think that God has provided all of these people that have all of this knowledge and all of these things that can help us that we should ignore. And so I was able to get her into care, and actually she's doing fantastic now because I reached her where she was. And so sometimes we just have to dig a little deeper and figure out where people are to reach them where they are. So I tell people all the time, God and the therapist works for me.
I love it. Have you heard that? And I forget the full story, but it was basically there was a big flood and this guy is on his roof and he's like, God is going to save me. Somebody comes in a boat and he's like, no, God is going to save me. Somebody comes in a cruise, God is going to save me. He ends up dying and he gets to God and he's like, what happened? I thought you were going to save me. And it's like, I sent you a boat. I sent you this. And it's almost the same that people sometimes forget that sometimes your doctors, your nurses, your social workers, etc. Those are the healers that God is sending into your life, depending what your beliefs are and whatnot. Beautiful. Thank you so, so much for starting this topic. I think everybody needs to address their mental health, especially those with a chronic condition such as sickle cell, with that unpredictability and just it truly impacts the entire family. So we're focusing just on the patients, but even caregivers, we should be encouraging. And just as providers, we carry and absorb so much energy and stress from patients and what we do day in and day out, that it is so important for us to prioritize our mental health so we can really show up and not get burnt down and really do our best and be our best and just be that mirror for our patients and what they want to embody and experience. So thank you very much. I appreciate it. If anybody happens to have any mental health resources that they give out to patients, or if they have any apps or recommendations that their patients are using and they like, feel free to respond to Sonia, Ashley, or myself in the group, and we can disseminate and share with everyone. That way we're not just trying to reinvent the wheel, things of that nature. So now for the last half of the presentation or the echo session, we're going to be doing a case study or a case report. Ashley is, I know the weather in Maryland is affecting her train commute. Ashley, are you able to present, or do you want me to present for you?
Nope, I'm here. This was perfect timing.
Good.
Yeah, I know all of my further north friends did not get as much snow as we did in Maryland. Even in Philadelphia, not as much snow as in Maryland. So it's been interesting, a couple of 48 hours. But this is the case of a patient that I previously saw in my previous practice. So he's a 48-year-old male with hemoglobin S beta null thalassemia. His last, you can see this is sort of an older case. So he had come into clinic. This wasn't an inpatient visit. He had come in with fatigue and hip pain. His hip pain was chronic. And he had had 2 admissions in the past 30 days. And in those before those previous admissions, he had not had an admission for a couple of years. His hematologist was Dr. Lanscron, primary care was Dr. McCoy. And again, he has this chronic bilateral hip pain, but not all that severe. He rates it a 1 out of 10. Does not, have, he has oxycodone as needed for pain that he takes on a fairly regular basis, but not a whole lot. Like he typically has 45 tablets that last him about 2 to 3 months. And however, he's received 20 tablets and then 30 tablets like in this sort of short interval time before coming into clinic, sort of right at the end of his crisis. And he's still been taking the medication a little bit more regularly than what he had been taking previously. If someone can scroll down for me, sorry. Thank you. He was not admitted, so no IV pain medication. He does have a history of acute chest and stroke and no history of DVT, PE, cardiomyopathy, pulmonary hypertension, does have renal disease, and does not have iron overload. Does not have a history of major depressive disorder, bipolar disorder, or substance use disorder, and no history of aberrant use of opioids. He's not in psychiatric care. He's currently on hydroxyurea, and his last ANC was 4.6. So he's been on hydroxyurea for several years and has had episodes where he's become neutropenic. Where we've had to hold the dosage or reduce the dosage. So the most recent dosage that he had been on was 500 alternating with 1,000. But then again had this, sort of second neutropenic episode where his ANC was 700 and we reduced him to 500 milligrams a day. And that's sort of where he has sat over the last, couple of months. Because he really was on a pretty suboptimal dose of the hydroxyurea, we trialed chronic transfusions with him. He did get transfused in January of 2019 and then got another 2 units prior to that, like while he was in the hospital, sort of starting him on transfusion. So he had gotten a total of 4 units when starting him on transfusions that sort of started at the end of his hospital stay. You can see his vitals are here. His pulse is 68, blood pressure 124/69, temp of 37.1, 96% done room air. His most recent hemoglobin after transfusion was 8.6 and 26.3. And that was sort of around where his baseline had lived. But then when he came back in his most recent CBC, his hemoglobin was 7.4 and hematocrit was 23.6. His white count was 5. His neutrophil was 4.6. His MCV was 77.6, and platelets were 223 with an absolute retic of 196. We did get a hemoglobin electrophoresis on him, and his hemoglobin S was 79.5%, and hemoglobin A was less than 5. And this was just a couple of weeks after getting those 4 units of blood. So they were completely gone from his system. He did not have any hemoglobin A. You can see his creatinine's 1.3, which is about his baseline. He's kind of 1.2 to 1.3. His total Billy 1.6. Urine toxicology screen was positive for oxycodone, which was appropriate because we prescribed that. He had a negative DAT. So when we saw these results of the hemoglobinopathy panel, we did a DAT, which was negative. His urine actually was also negative for hemoglobin pigments and did not have any history of antibodies. And the blood bank did not find any antibodies on his type and screen. You could scroll down. So no recent radiological testing. He works full-time as an engineer. He's married. He has private insurance and lives with his wife. So our biggest concern for this patient, right? So he doesn't have any history of antibodies. His DAT was negative, didn't have any hemoglobin pigments in his urine. However, there was no hemoglobin S post-transfusion. And without those findings, like, can this still be a hemolytic transfusion reaction? And with a likely reaction, we were going to stop chronic transfusions for him, and he really hadn't been able to tolerate anything higher than 500 milligrams of hydroxyurea. So what other therapies could we consider for him?
Nice. Okay, so to summarize, we have a 48-year-old man with sickle beta thalassemia 0. He has history of kidney disease, acute chest syndrome, has been on hydroxyurea since 2018, but reduced doses because of the low ANC. He's been transfused. Baseline hemoglobin, or most recent, was 7.4, creatinine 1.3, and the hemoglobin F was 9.8, which I thought was, well, at least there's some effect of hydroxyurea, even though he's not on a full dose. But then there's the concern because there was minimal hemoglobin A and whatnot following his transfusion. So does anybody, I don't want to just speak everybody's ear off. I want to give everyone the opportunity to participate as well. But does anybody have any clarifying questions or comments regarding this case and with regards to transfusion or delayed hemolytic reactions? All right, good luck, Ashley. I'm just kidding.
Okay.
So there's a few things
No,
that
I mean, I think this is. Go ahead,
it is
Maya.
hard because the first, when I saw it and I was reviewing the case, my first thing is I would have repeated the electrophoresis and see, like, is it actually true and whatnot? Is there really no response at all? And it's hard because I think we've had cases similar where they get transfused and they literally have no bump in their hemoglobin and they don't have any of the confirmatory testing for a reaction. From a hemoglobin optimization standpoint, I'd be curious, like, what's his EPO level? And I, like, usually anytime I have a patient with any type of kidney dysfunction, I'll always do like a parathyroid hormone, check for protein in the urine, and also do an EPO level and just make sure that the EPO is what we would expect for the degree of anemia, to see if there's any production issues as opposed to destruction from the sickle cell standpoint of those things. And then just from a kidney standpoint, I think it's called, is it called the SC Cares trial, where they're looking at transfusion to maintain kidney function? It's hard because they randomize it, so only half will get transfused and the other half might get just whatever the standard of care is. But that's a route that you could consider. I don't know if you guys heard, but I heard this statistic last year and it's just stuck out to me so much. But we know that individuals with sickle cell, the creatinine is not a reliable test because the creatinine is usually low, just since we don't concentrate urine as much, etc. So if we're waiting for the creatinine level to get elevated, you're going to have advanced kidney disease, which has a very poor prognosis, where once you have a patient with sickle cell have a creatinine greater than 1.5, in 3 years, they're either going to be on dialysis or die. And I think, like, as soon as I heard that statistic, I take kidney function so much more seriously from a sickle cell standpoint. Even like I've educated a lot of our nephrologists who aren't aware of that because they get very casual. They're like, oh, 1.3, not a big deal. But I would just be if this was my patient, I would really focus on the kidney function and make sure that there's not a production issue. Was this the only episode where he's had no hemoglobin A response after transfusion, or has that happened previously?
So this is sort of old. And so we sort of, so this was a visit in 2018. Then in 2022, he came in and ended up, unfortunately, with multi-system organ failure, and we needed to exchange him. And he did a very similar thing to this. We were able to get him through that acute episode. he at that point did not illustrate anti-antibodies. We did support him because at that point, like he did fit like the criteria for DHTR, like his hemoglobin went down pre-transfusion guidelines, and we certainly exposed him to a lot more blood than what we had exposed him to previously. So we ended up giving him IVIG steroids. He ended up doing okay, went home and tolerated things. So I think that's like the hard part of this, right? Is that and Dr. Merrill, who was at Hopkins, who's now at West Virginia, did do some research when we were both at Hopkins, looking at complement response in patients that with sickle cell disease. And so I think that, and he did find that there is some complement mediated responses that happen, which makes it even harder for some of these patients because like the ones that are heavily alloimmunized, you know what the problem is, you know how to identify the problem in general, right? And so, but for these patients that don't have any developed antibody, it just makes it really, really challenging. So we were able, luckily, to support him through. He would be somebody, he's an interesting case, right? So in some patients that have cytopenias with hydroxyurea that have renal disease, right? Like we can try EPO, right? With Hydrea, if it's like the retic response we're thinking about, but he was just so interesting that like he became neutropenic with it, which I think is fascinating in itself. And maybe there's some other etiology that needed to be identified for him. But I agree, maybe clinical trial for him potentially. We don't do SCD care here at Jefferson, but we did do SCD care at Hopkins. We have the hibiscus clinical trial here at Jefferson. So he, if he was here with me still, potentially that would be an option for him. If we're thinking to like shoot for a higher hemoglobin level versus, our true like disease modification. And definitely the same sort of experience with renal disease. So like the NHLBI actually recommends that urine microalbumin screening happens at the age of 10. So right, like even children, right, should be having the screen. And we have a woman at Jefferson that spills over 1 gram of protein into her urine and has a normal creatinine. So like it's just not a great, like you said, it's just not a great test for our patients.
And then also from a kidney function standpoint, we start at age 10. And if with most of the screening tests, they all begin at 10, like even with getting your eyes a full dilated exam, et cetera. So say a 10-year-old has protein loss in the urine, it's not expected, but we also know that there's genetic risk factors like the APRN gene, which is higher risk in African Americans. So when we think about racial disparities and whatnot for health disparities for kidney disease, we know that African Americans are higher risk, and there is somewhat of a genetic component. We know there's structural racism and systemic racism that plays into it, but we check it early because sickle cell obviously is a big offensive agent towards causing kidney damage, but there are other risk factors from a genetic standpoint, lifestyle, medications, other history, et cetera. And then
I've also seen, and this is going, no, I was going to say this is a way off, sort of a little off topic, but I've had patients, quite a few of them in both practices that have had underlying autoimmune disease, like have rheumatoid arthritis, that is actually ended up being the cause of their nephropathy. Like they've had a renal biopsy and they've actually diagnosed it. And the sickle portion, right, wasn't maybe the underlying cause, but sort of was fuel to the fire.
Yeah, no, and I think that's why it's so important just for any type of ailment or complaint that our patients have. Sickle cell can cause pretty much everything, but it's important for us to rule other things out before just blaming sickle cell. And then if you had a patient where this were to happen, like we're fortunate, we have our pheresis department and we have a really good coagulation lab and experts from that standpoint, that I would probably involve the blood bank and our pheresis and coagulations and pathologists to kind of like look at this person's blood and see what's going on and see if there's anything that might not have been detected on the antibody screen, but maybe has something that is contributing from that standpoint. And just from a treatment standpoint, you talked about the hibiscus study, but it seems like we're hopefully by the middle of this year, we're going to start to have additional treatments to offer our patients from a sickle cell standpoint. So right now we really just have hydroxyurea to raise hemoglobin. So hopefully by Q2 or so, we will have other treatments to offer our patients, and hopefully they trust it compared to what happened with Pfizer. But a lot going on behind the scenes. And I think as providers, we have to let our patients know, because for us, we see it, but for our patients, a lot of times they have the same story of like, oh, nobody's listening to us, nothing's changing, this is all the same. But in my opinion, there's so much going on, and we're about to just like kick off in the beginning of this year and in the upcoming years with so many treatment options, that I think it's important for us to just let our patients know what's going on behind the scenes. Does anybody have any questions, comments, feedback for this echo session? since we have a few minutes, I just want to spend 2 minutes just to talk about something that's interesting to me. And I think as providers, it can really help us as we practice. And I love, obviously, as a hematology nurse practitioner, I practice Western medicine, but I think a problem with Western medicine, it's like everything, it solely treats the physical body. You have a symptom, here's a medication to treat it, where Eastern medicine kind of focuses more on that mind, body, and soul. And I don't think it's one or the other. I think there's duality with everything in life, with day and night and fire and water and Eastern and Western medicine. And it's really about finding a balance and a harmony between the two. So I think from an energy standpoint, like when as we are all healers, like we all chose nursing or to be into this field to help people that like we probably, if you believe in past lives, like we are innately healers. And because of that, a lot of us are empaths, meaning we absorb a lot of people's energy. That a simple practice that we can do is ground ourselves. And grounding is literally just making sure like you are connected to the earth and just in your body. Because when we're stressed or we're anxious or we're having certain symptoms, we're out of our body. We're either focusing on the future, we're ruminating on the past, but we're forgetting to be in this present moment. So I think it's important for us to regularly just check in with ourselves, because our body, just like when we're dehydrated, we can have different skin trigger, we get thirst, we get chapped lips. When our energies are blocked or there's some imbalances, we get warning signs too. So just tune into your body and just see, like, are you having any tension or tightness? And when you can get connected to your body, it allows you to kind of ground yourself. So that way, when you're going into treat patients and going into work, when life happens and stressors come and patients are putting on a lot of heavy stories on you, it doesn't affect us as much. So just a simple grounding thing that you can do is literally just take slow, deep breaths and be very intentional. You can even imagine like roots growing out of your feet into the earth's core, and just like breathe into that of just with the intention of grounding yourself for the day. And I bet you, if like literally before I get out of the bed, I spend the first 1 to 2 minutes doing breath work, my little grounding visualization exercise, and I get out of the bed and it's like my kids and the chaos of being up at 5:45 in the morning, you'd have no idea. So just a little practice we can do as providers. And with that, Sonia will be putting a link in the chat so we can all get our continuing education credits, which I always forget to do, but that's okay. But we'll have the link to get that. And if you have any questions, concerns, or feedback, our emails are always open. If anybody's ever interested in presenting, it's an awesome opportunity just for professional growth, or if you've never presented before, 20 minutes is a really non-threatening opportunity if you want to kind of dabble into that. And then if you ever have any interesting cases or difficult cases that you want to bring and just kind of explore what other options there could be, or maybe things that you haven't considered, feel free to let us know. So with that, I give you 7 minutes back to your Tuesday. I hope everybody has a wonderful week, and we will see you back. There's a lot of Echo sessions coming up, but this is the one that's once a month, the first Tuesday at 9 a.m. Eastern time. So I'll see you back next month, and maybe at some of the other Echo sessions this month. Take care, everyone.
Thanks, Maya.